owners, advertisers, and management company of Sugar City FM 90.3. Nor are such statements necessarily supported or endorsed by the advertisers of the station. While we encourage all to share their opinions, we do not support any comments that may slander, discriminate, or otherwise offend anyone, and we insist that you refrain from any such statements.
Fellow citizens, near and far, join Nearest Natal on Sugar City 90.3 for Fear No Favor.
Where is the cancer man who wanna come out for war?
Tune in to 90.3 on your FM dial. Log on to SugarCityFMSankits.com or download Simple Radio app from the Google Play Store. And join Newish Natal every Thursday night from 8 to 10 p.m. as Newish Natal tackles the issues and take your calls. Fear No Favor every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Good evening and welcome to Fear No Favor. And I have with me our General Surgeon in the person of Dr. Natalie Osborne. Remember, she came first and we spoke about the do's and don'ts about getting prepared for surgery and some ways forward as to what you should do to make sure that the recovery is close to 100%. And then she came back the second time and we did acute appendicitis. And I think that was well received based on the reviews that I've been getting from the general public and my followers. And now today we are going to be looking at the gallbladder. Mm-hmm. So, Doc, welcome again to Fear No Favor.
Well, good evening to our listening audience. It's so good to be here with you again this evening. So thank you for being so generous to me and having me here on your program. It's been a pleasure so far to be discussing these health topics, specifically surgical topics with our audience, because our goal ultimately is to educate the community so that persons are much more aware of the different conditions that can affect their bodies. And I always believe that as an individual, you're ultimately responsible for your health care, and it's a partnership. So your knowledge ultimately helps you in seeking the necessary attention, medical attention when needed. So once a person is much more educated on a topic, they can oftentimes inform the doctor. A patient is actually their best advocate ultimately, and their family, pointing out sometimes that things that a doctor may overlook. As you know, the person is able to describe their symptoms, their signs, because they would have experienced it for much more time than a doctor. They visit with a doctor, the visit is 15, 20 minutes, and then they are gone. So that is why it is important to educate our audience so that in the future they are able to appreciate and have the depth of knowledge so that when anything happens to them physically, they can often point out and be their own advocate and insisting and seeking medical attention.
And programs of this nature can be rather instructive because
yes, they can.
If you start to feel odd, because all of us know how we are supposed to be feeling as individuals.
Correct.
And if we start feeling a bit odd, this program will tell you, look, start taking notes, taking a little bit of notes as to when this started, how I was feeling earlier, how I'm now feeling, how the pain is progressing, how the feeling is progressing on a whole. So you can at least help the doctor to help you, because you cannot go and stand in front of a doctor and say nothing and just expect the doctor to attend to you. You have to lay the foundation. It's like a lawyer in a courthouse building the foundation on which he's going to make his submission. So programs of this nature, I had a few persons who said that they're really enjoying it and they're learning more and they start to monitor themselves even more closely.
That leads me to just bring out a point before we go into the topic, is that persons are different. Their level of education, their level of their ability to express themselves. And sometimes a patient comes in front of a doctor and a patient might not be as good as historian as another patient. They may not have the ability to express themselves and relate their symptoms and explain as well as someone else. Because I've seen patients who come in and they tell you all their signs and the symptoms that they've had and they're able to express themselves. And others come in and you have to pull the information out of them. So we have different persons in our community. Hence the importance of education, so that, they can become a little bit more exposed and be more familiar with the medical terminology and some of the symptoms and associated with these different disease topics that we're going to be exploring.
Okay, great. So at the nucleus of our discussion for tonight would be the gallbladder disease. Doc, what is gallbladder disease?
Well, anything that can affect the gallbladder. And for our audience who are not in the medical field, the gallbladder is a small organ that lies just under the rib cage. It's intimately associated with the liver. It is a small organ, and the main function of the gallbladder is to store and concentrate the bile. Bile is an important substance that is made by the liver, and it goes down the bile ducts and it is stored in the gallbladder. And it is needed for when we eat a fatty meal specifically. So for example, you're having a night out with your friends and you have some ice cream or you have a pizza. Once that pizza gets into the stomach, it's being digested, and then that is then released. The chyme is released into the small intestines, and that immediately sends signal to the gallbladder that, hey, there's a fatty meal, there are fatty foods here to be digested. And that gallbladder then it receives the signal, it contracts and it ejects the bile that goes down in the bile ducts and enter into the small intestines, specifically the duodenum. And that bile is responsible for the emulsification of fats, or the breakdown of fats. That is the fatty enzyme, the fatty meal that we would have eaten.
Okay.
So you ask specifically, what is gallbladder disease? It is anything that affect the gallbladder, and there are different things that can affect the gallbladder, as we would speak about. So the gallbladder can become inflamed or infected, what we call like a cholecystitis, and that is usually as a result of having gallstones. I'm sure many persons in the community would have heard about gallstones. You say, you have a friend or family who would have had gallstones, and gallstones are formed inside of the gallbladder because I remember you taught me chemistry, because of the saturation of the constituents of the bile. One of the main components of bile is cholesterol. And so once the cholesterol becomes super saturated inside of the bile, it then crystallizes, as you would say, or forms stones. And that is usually how gallstones are formed. And then gallstones in the gallbladder can lead to many different conditions. It can block the gallbladder outlet and give you colicky pain that we call biliary colic. It can then become infected, what we call acute cholecystitis. You can also have gallbladder cancer, which is, although very rare, it is still something that it would be important for our hearers or listeners to know about. You can also have a polyp, or a normal growth from the lining of the gallbladder. So there are different conditions that affect the gallbladder. But the most common condition that affects the gallbladder is gallstones, having gallstones there, and these gallstones can lead to different complications.
Well, you jump in the gun on me. In 100 meters, you would have been disqualified. You have to wait until
I'm sorry.
Yes, but that is okay. I realize that we are quickly developing a nice rhythm. I like the trajectory that we are on. and I don't want to disrupt that rhythm. But I want to ask a question. Is there a difference between gallstone and kidney stone? It's just the area of origin?
Yes, because most gallstones are the stones formed in the gallbladder, or we call them calculi or calculus singular, but they're completely different stones because stones that are formed in the kidney are different type of stones that are formed in the bladder. Those in the kidney are usually as a result of infection, different conditions, and most of them are made from calcium, has a calcium component. The stones that are formed in the gallbladder, those are usually as a result of cholesterol, but there are different types of stone as we'll talk about later on. There's stones that are formed when a person has things like sickle cell disease that we call pigmented or bilirubin type of stones. And most of the stones are the most common types of stones are cholesterol stones because of high cholesterol in the body. And so as one of the components of the bile, because the bile is made up of phospholipids, it is made up of bile salts, it is made up of water, and it also has cholesterol in it. And then once the cholesterol becomes supersaturated or it becomes more high in concentration, then you have the gallstones. But these are separate organs, to go back to your questions, and these stones has nothing to do with each other. So one is in the kidney that can affect the kidney that we call kidney stones or renal stones or nephrolithiasis, and the gallstones are called cholelithiasis, two different systems.
You know, that is interesting. I can recall when I was in the second part of sixth form, I felt some terrible pain. You know, like somebody got something rooting along your bladder, so to speak. And it was really intense. I really couldn't take it anymore, so I went to the hospital. And I think it was Dr. Jacobs who gave me, because I went to Molyneux back then, gave me an injection to relieve the pain. But then they're telling me that they don't think was stones, whether gall or kidney. And I monitored my urine, and then I saw something like, inside a pomegranate, that sort of shape. It came down, and of course, it did me real badly. And I took it to the hospital, and I showed them, look, you told me that none was present, but look here. So I assumed then, since it came down the urinary tract, that it might have been kidney instead of gall, because gall would more be down the digestive system rather than the urinary tract.
Correct.
Am I
You're
analyzing
correct.
this thing properly?
Yes. So you can have stones within the kidneys, and if they're small enough, they can pass through the tract that is called the urethra, go into the bladder, and you can excrete some of these stones. But our main topic for this evening is the gallstones, which is a complete different organ.
Yeah, that's all right. I just wanted to know because it
clarify.
really gave me some intense pain.
Yes. Pain associated with kidney stone is extremely intense.
Real intense. What are some of the conditions that affect the gallbladder? You might have alluded to them already, but I hope you don't mind repeating them.
No, it is important because repetition is the mother of learning, and we're here to educate our audience. So we said that the gallbladder, the most common condition is gallstones, or we call them cholelithiasis. It is very common in our society, usually more frequent in women than men. Once you have gallstones, though, that can lead to several different problems associated with it or complications. Because if you have gallstones, that can then block the duct from the gallbladder, that's called the cystic duct, and give you an infectious process, which is called cholecystitis. And very often we have patients who come to the emergency room with abdominal pain, which turns out to be cholecystitis or having cholelithiasis or gallstones. You can also, if you have a gallbladder that is not functioning well, okay, in terms of the musculature and the nerve system, we call that biliary dyskinesia. Okay, that is the malfunction of it. There's no definitive stone there, but because the function is sluggish, there can be sludge or thick thickening of the bile inside of the gallbladder, but not specifically a stone, and that gives the patient significant discomfort and pain from time to time, especially when they eat a fatty meal. You can also have polyps inside of the gallbladder, and that is of concern, and also you can have gallbladder cancer. Though rare, it can happen in a small percentage of the population.
Could we take a break and come back?
Fellow citizens, near and far, join Nearest Natal on Sugar Soda 90.3 for Fear No Favor.
Where is man? Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to SugarCityFMSankits.com or download Simple Radio app from the Google Play Store. And join Nourish Natal every Thursday night from 8 to 10 p.m. as Nourish Natal tackles the issues and take your call. Fear No Favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
nation, building a brand new nation. We move on together hand in hand. Rise, citizens, arise. The country is yours, all yours, still yours. Can your conscience be clear? Indulging corruption or misusing public office, being accused of unemployment.
Well, welcome back to Fear in Our Favor, and we continue our discussion on the topic gallstones, and I think that we have been very instructive thus far, and we are happy that persons are tuning in and telling us that they're loving the information that is being given. Now, Doc, how common is gallbladder disease?
Well, gallbladder disease affects approximately 15% of the population. So usually in that group of persons, they would likely develop gallstones, as we said, which is more than 90% of the most common condition that affects the gallbladder. And in that 15%, roughly around 20% would present with signs and symptoms or a complication as a result of this gallbladder disease.
So you're saying out of every 100 persons, at least 15 to 20?
Yes.
Did I hear wrong when you said some would show out of that 15, some would show symptoms and some might not?
Yes, because what I say when I say that is that it can be an incidental finding. Some persons could have gallstones in the gallbladder all their lives and never have a symptom, but some persons will develop symptoms and complication as a result of having the gallstones. So then we're saying that if you were to take maybe 100 person and you randomly do a study like an ultrasound looking at the gallbladder, you may find about in 15 of that 100 person may have gallstones within the gallbladder. And that what we call an incidental finding, because unless you went to look for it, you would not have found it. So they may never have symptoms of that 15%, we say approximately 20% would develop some sort of symptoms in their lifetime.
Earlier you indicated that it is more, comparatively, it is with females more than males.
Yes.
Would that same percentage hold if you just examine 100 females as opposed to 100 males? It would still be between 15 and 20?
Yes, well, I think in the general population.
General
In the
population.
general population, that data was given.
Whom does the gallbladder disease affect?
Okay, so when you speak about the affecting the gallbladder disease affecting, we're talking about things like our risk factors. And so one of the most common risk factor is just being female. And I'll tell you why, because there's certain things about the female, especially we have a higher concentration of the hormone estrogen, and that puts you at greater risk for developing gallstones. So it is much more frequent in females than in males. Also, it is more common in females above the age of 40. Usually, once you pass the age of 40 above, you start having symptoms or present with gallstones. It is often seen in females also that are multiparous, that has had multiple pregnancies, We know in pregnancies, there are a couple of things that happen. There's a significant increase in your estrogen, which we said is a risk factor for developing gallstones. And as the fetus grows and it compresses the stomach and the different gastrointestinal organs, they can have stasis. And anything that is stagnant, when we speak of stasis, we're speaking about stasis inside the gallbladder. So the bile becomes stagnant, and then it has a propensity to develop or create or form gallstones. So that is some of the risk factors. Also, it is seen often in patients who have high cholesterol. We explained earlier that most of the stones in the gallbladder are what we call cholesterol stones. It is seen often in patients who are obese or overweight, as these patients, excess weight causes your body to produce excess cholesterol. So those persons tend to have higher propensity for developing gallstones. All right? It occurs most often in persons who has a family history of gallbladder disease. We said that about 25% of gallbladder disease is hereditary, so there likely would be some relation in the family. All right, persons who have diabetes are at increased risk. Persons who may have cirrhosis of the liver, which we know that cirrhosis is destruction of the cells or hardening or fibrosis of the hepatocytes or the cells within the liver. Persons who have disease such as sickle cell anemia at increased risk of developing gallstones, and these gallstones are usually what we call bilirubin stones or pigmented stones. Persons who have other associated diseases like Crohn's disease as well. These persons are twice as likely to develop gallstones, okay, because the gallbladder or the gastrointestinal tract in these persons with Crohn's disease has a decreased ability to absorb the bile salts, and those bile salts help to break down the cholesterol. And we know, as we repeat again, that most of the stones inside of the gallbladder are what we call cholesterol stones. So if you don't have the bile salts, you would have a higher concentration of the cholesterol. So there are multiple different risk factors, as also like total parenteral nutrition. That's usually occurs in patients who are fasting, or they're not using their gastrointestinal tract, or they're hospitalized and they're being given nutrients via their vein. That is what we call total parenteral nutrition. And it's important to use your gastrointestinal tract so that the bile can be released by the gallbladder. If that does not occur, the bile stays inside of the gallbladder. And anything that causes prolonged stasis, or the bile is retained in the gallbladder, it increases the chance for it to form gallstones.
So when we were given instructions to fast and pray, did we increase the risk of us developing gallbladder disease? Because you just indicated that the system must be active so that the bile can flow to areas that it would need to go to. So when people fasting, is there a danger that it might lead down the path to gallbladder disease?
Well, anyone who has prolonged fasting would increase their risk, because prolonged fasting, but most of the time I would think our fasting are for several hours. If we're doing intermittent fasting, 16 hours, or religious fasting, that might be a day or so. But prolonged fasting does, because once the GI tract or the gastrointestinal tract is not active, then the bile is not going to be secreted. So then the bile stays in the gallbladder, and once it stays in the gallbladder, we have the stasis, and we can develop or create gallstones.
That is interesting, but if you fast and pray, we like to assume that that supreme being, of which something greater can be perceived, would tend to take care of you during that fasting period and do not subject you to any increased probability of gallbladder disease, gallstone disease.
But remember too, we have, when you speak about risk factors, we have some risk factors that what we call give you a higher chance or higher probability of developing the disease. And prolonged fasting is on the lower end. We spoke about being a female. We spoke about your age, advancing age over the age of 40. We spoke about obesity, having diabetes or disease like Crohn's disease. Those are higher. Those are diseases that predispose you of developing gallstones much more than a prolonged fast or fast for 24 hours.
I'm very happy that I'm a God-fearing person, so every time I fast, I pray as well to prevent that increased probability. So that is why that combination of fast and prayer should go together. Just can't say fast. Okay, what are the 5 F's of gallbladder disease?
Okay, I mentioned a couple of them, and it is important because if you cannot remember all of the risk factors, we often use this mnemonic of the 5 F's. We said earlier females because of the increased estrogen. So females are at increased risk of having or developing gallbladder disease. We spoke about being fat or have a high body mass index, and anyone who is a little bit obese or overweight have an increased risk of developing gallstones. We spoke also fertility. When we speak about fertility, we're talking about women who are multiparous. Each time a woman becomes pregnant, she increases her estrogen. As the fetus grows inside of the uterus, it causes stasis in the gastrointestinal tract, prolonging the bile, promoting stasis of the bile in the gallbladder as well. We also spoke about, we said, fear. Another mnemonic is fear. Usually gallstones is seen in the white population, the Caucasian population. It is not known exactly why, but sometimes we speak about in first world country, the developed countries, they have a high a diet high in fat and low in fiber. So it's more common in in white females, women over the age of 40, women who are fertile.
Yes, sometimes we have some disease that are race-related because I think that sickle cell anemia affect more black persons than white, but at the same time, you have cystic fibrosis that would affect white with a white person disease as well. Now, we're going nicely. What are the complications of gallbladder disease? What are some of the complications?
Okay, and I just want to make sure that our listening audience is aware of what we mean when we say complications. So as a result of having gallstones, it means it can lead to some serious health problems. So that's what a complication is. So with gallstones, we said gallstones can sit in the gallbladder for many years and cause no problem. But then if there is a blockage at the exit point or the cystic duct of the gallbladder, that can create problems such as biliary colic, that is the colicky abdominal pain that one gets once they eat a fatty meal and the gallbladder is contracting, trying to release the bile from the gallbladder. And in that way it is contracting, it is going up against an obstruction because the stone is there blocking the outlet, and that patient could have severe crampy abdominal pain. You can also, if that stone or that obstruction remains for a long period of time, the gallbladder can become infected or it becomes distended. Then there's edema around it. Okay, the walls become thickened, and then you can have what we call cholecystitis. Also, in patients, they have multiple stones within the gallbladder. Some of these stones are very tiny. And what happens with this stone? If they leave the gallbladder, by the outlet, they can get into the common bile duct, or one of those ducts that leads the bile from the gallbladder into the duodenum or into the small intestines. And if that stone gets stuck anywhere along the path of the common bile duct, along that track, it can give you severe health problems. We call that cholangitis, or the gallbladder duct or the common bile duct becomes inflamed. And anytime you hear, and we said this in an earlier program, once you hear the term itis, it alludes to some sort of infection or inflammation. So cholangitis is the infection or the inflammation of the common bile duct. it can lead to things like biliary pancreatitis as well. That is another complication. And what is biliary pancreatitis, you ask? That is where the duct from the pancreas becomes blocked as well, giving you pain and severe infection or inflammation in the pancreas. Because once the pancreatic duct is blocked, the pancreatic juices that are released by the duct in order to aid in digestion as well, those are obstructed. The release of these enzymes are obstructed, and then the pancreas becomes distended and inflamed, and there's something that we call destruction of the pancreatic cells. So some of these are complications that you can have. If the gallbladder also becomes so inflamed with an infection, the gallbladder can then become gangrenous or rotten, as we say in the local terms. Okay, and then if it goes on like that, we have cases where the patient can have a perforation, because once the tissue becomes necrotic or dead, there is a breakdown in the wall, and there can be infection or pus that releases into the abdominal cavity, causing sepsis and severe health complication.
Did you indicate that, like the appendix, that you can have rupture of the gallbladder?
Yes. Yes, quite similar, because the pathophysiology of acute cholecystitis is quite similar to the pathophysiology of acute appendicitis. And what do I mean by that? The way that the infection progress, remember we said when we spoke about acute appendicitis, it starts usually with an obstruction. It always starts with an obstruction at the outlet or the entrance of the appendix. In that same way, acute cholecystitis would start with an obstruction at the outlet of the gallbladder. And once that obstruction begins, there is distension of the gallbladder, there is increase in bacterial growth, there is it then affects the blood vessels that are the veins, then the artery, and that can lead to ischemia and later perforation. And that is what we want to avoid in our patients.
Okay, could we give the good doctor a break? So could we take a break and come back?
Fellow citizens, near and far, join Nourish Natal on Sugar Soda 90.3 for Fear No Favor.
Where is the cancer and no runner come out for war?
Tune in to 90.3 on your FM dial. Log on to SugarCityFMSaintkits.com or download Simple Radio app from the Google Play Store. And join Nourish Natal every Thursday night from 8 to 10 p.m. as Nourish Natal tackles the issues and take your call. Fear No Favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
going off constantly?
Welcome back to Fear in Our Favor with the good General Surgeon, Dr. Natalie Osborne. Now, Doc, we have been giving the public some good information with respect to gallbladder disease, but something key, something that is at the nucleus that the general public would really want to become more au fait with is the symptoms. What are the signs and symptoms of gallbladder disease?
Okay. If you don't take anything else from this session, I would like you to keep in mind the signs and symptoms. That's always the heart of our discussions, to educate our listening audience so that once they have any similar symptoms, they can seek medical attention. Because an educated community is an empowered community. So the common symptoms or the classic symptoms associated with gallbladder disease are usually pain in the, what we say, the right upper quadrant, or that is just under the rib cage there on the right side. That pain is usually associated, or it's brought on after the person would have had a fatty meal. Remember, we spoke about the function of the gallbladder is to release the bile when someone has ingest a fatty meal. So we say that there's pain associated with fatty food intolerance. So that once you eat something high in fat, that pain comes on as the gallbladder contracts against an obstruction. So there's pain right under the right side of the rib cage. We say the right upper quadrant. Any pathology or any disease that affects the gastrointestinal tract can also bring on nausea and vomit. The patient can have nausea or vomit. And if there's any time we have a presence of an infectious process, you can have nausea and vomits, and you can have fever as well. So the person may develop fever or feeling chill. That is when you feel like everybody else is feeling good and say that the day is fine, but you're feeling extra cold. So you're having those chills and fever. You have pain in the right upper quadrant. You can have nausea and vomits. Sometimes these patients may have things like jaundice, and jaundice would indicate, jaundice is the yellow discoloration of the eyes, and that indicates a serious complication of the gallbladder disease. We spoke about something like cholangitis. Cholangitis, earlier we said that cholangitis is a complication of gallstones or gallbladder disease. And once you have jaundice, it is indicating that the common bile duct, or the duct that leads the bile from the gallbladder into the intestines, that may be blocked. The person can also have rapid heart rate, or they can have palpitation. The heart is beating extra fast. That is usually an indication that there's some kind of fever or infectious process. The person can also have distension or bloating of the abdomen. That is always a concern too if you're having pain, and then after a while you start realizing that your tummy becomes bloated. Okay, and in some period the person may have things like diarrhea and stuff. But the main symptoms associated with gallbladder disease, to some extent or another, you have the pain in the right upper quadrant, nausea or vomits, fever, fatty food intolerance. That means that once you eat a fatty food, the pain in the right upper quadrant is usually brought on as a result of eating foods high in fat. And that pain can radiate to the right shoulder or reflect, or they can feel that pain in the right shoulder.
I want to ask a mathematical question. When we speak about the quadrant, I just had a math class and I was teaching some graphs, and I told them about the 4 quadrants, but they don't always have to be equally depending on where you're going to put your scale. Where is the dividing line on a human body for you to put that body into 4 quadrants? Quadrants would mean 4. Where is the dividing line in med school or within the surgical environment?
Okay, the dividing line is through the umbilicus. So you have a vertical line. That vertical line can start from the sternal notch, that is right here, where I'm pointing to, and go right to the umbilicus, right down to the pubic symphysis. That's your vertical line, so that divides it into right and left, and then you have a horizontal line that runs right to the umbilicus or by the navel, and that divides it in upper and lower. So then we have 4 quadrants. We have the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. And dividing the abdomen into these quadrants is very significant in medicine, because it indicates to the doctor, based on where the person is having pain, it may suggest what organ is affected, because then you are aware of what organs is located in that particular quadrant.
Seems as if the upper quadrant is where most of the problems might be, because you have more organs above the upper part. Because you only have a few below.
But that
the
is
horizontal
relative.
line,
I would not. That is relative, because in a female, we can have lots of problems in the lower quadrants, because we have the ovaries there, the fallopian tube, the uterus. So that is relative. It all depends on who is being affected.
The heart is above.
But the heart is not is not considered an organ in the abdomen, because when we're talking about the quadrants, we're talking about the abdominal
Just the
cavity.
abdominal-
Yes, the
oh.
abdominal cavity.
Just not the entire body.
No,
Just
we're talking about from below the diaphragm, or the muscle that separates the chest from the abdomen. So the abdomen is divided into quadrants, okay? And we say right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. And those are vertical and horizontal line going through the umbilicus.
Okay, thank you for that. Quick Matt 121, Matt 101. Now, how is gallbladder disease diagnosed?
Okay. Like most diseases, and I love teaching, so I'm always trying to give persons things to relate to and similarities. There are certain things you want to keep in mind. You want to make sure you get the history from the patient, so they'll tell you the story. That is very important in making a diagnosis. Once you get a good story from the patient, that could help you so much in making a diagnosis. So you want to hear them tell you, Doc, I've been having pain. So you ask, where is the pain? They'll say to you, oh, the pain is in my tummy, in the right side, just below my rib cage there. So that's a part of the history. They'll tell you, I would have had some nausea or vomits. I might have had some fever. These are patients who tell you the pain was brought on after I went out with some friends and had some ice cream. So that is the association with fatty foods. So once you have a history of this, and you have to keep in mind the risk factors and the 5 F's that we spoke about earlier. So usually it's going to occur more in females, usually occurs in women who are multiparous and stuff like that. So all that is a part of the history. Then the doctor is going to examine the patient. So to make a diagnosis, you always have to examine the patient. So the patient is placed on a gurney or on a bed, and the doctor goes touching the abdomen in different areas, especially in the right upper quadrant, and you're looking for signs. There's something called Murphy's sign. That is when you press the tummy and you ask the patient to take a deep breath in, and they have respiratory arrest. What does that mean? Because once you press in the right upper quadrant where the gallbladder is located, and you ask your patient to take a deep breath, what happens? You expand the lungs, the diaphragm, or that large muscle separating the chest from the abdomen, that descends and it pushes down the liver and the gallbladder. And that gallbladder, if it is inflamed or infected, once it comes in contact with the abdominal wall, the person would stop breathing, they'll hold their breath, and that is what we call respiratory arrest in that situation. So there's tenderness there. So you examine it. So once you go to the emergency room, you'll see your doctor examining in the abdomen, and they're looking for a sign that's called Murphy's sign, or they're looking for tenderness in the right upper quadrant. So after you would have done that, you can then do laboratory tests. You take blood samples from your patient, and you can send those to be tested. You can use your imaging studies as well to help make a diagnosis.
Could we take a break and come back?
Fellow citizens, near and far, join Nourish Natal on Sugar Soda 90.3 for Fear No Favor.
Where is man? Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to SugarCityFMSaintkits.com or download Simple Radio app from the Google Play Store. Enjoy Nourish Natal every Thursday night from 8 to 10 p.m. as Nourish Natal tackles the issues and take your call. Fear nor favor. Every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Would you stand up and see your country dying and never lend a helping hand? Would you see your children's future dwindling, creating much disillusion? Or would we watch on idly, disregard?
Okay, welcome back to Fear Nor Favor with our General Surgeon, Dr. Natalie Osborne, and we're dealing with the topic gallbladder disease. Prior to the break, we looked at how is the gallbladder disease diagnosed. She spoke to the history, the physical examination, the laboratory test, and imaging studies. Well, they were she alluded to them. So now we're going to give her a chance to maybe elaborate a little bit more by asking of her, what tests are used to diagnose gallbladder disease?
Okay, we mentioned the laboratory testing, and we also mentioned imaging studies. So usually we'll do blood works at the hospital. We get what we call our CBC, which is our complete blood count. And in that, we are looking at things like our hemoglobin. You're looking for your white blood cells. Your white blood cells is an indicator if there's some sort of infection. You're also in the CBC, there's your platelet counts as well too. So these are the main things that you're getting there, and your what we call hematocrit. These are the main things you're looking in your CBC. But in the case of gallbladder disease, the most common thing that you look for in your CBC is your white blood cells, because if that is associated usually with some sort of infectious process of the gallbladder, whether it is a cholangitis, a biliary pancreatitis, or a cholecystitis. You also want to do your complete metabolic panel. In that, you're looking at how your kidney is functioning. You're looking at your liver panel to see how your liver is. Remember, we said earlier that your bile is made in the liver, and then it is passed down through the ducts and then stored in the gallbladder. So once you want to check those liver panels to see if there's any signs of that there's damage to the liver, and that would be indicated with some of these blood enzymes are elevated. You also want to check to see what your total bilirubin is. That is, if the person has jaundice or yellowing of the eye, that is an indicator that your total bilirubin level might be elevated. So that would confirm that with you by doing that blood test, checking on your liver panels. There's also another enzyme that is very prominent in the biliary tree or the tract that takes the bile from the liver to the intestines. Those are called the biliary tree. And if there's damage or injury to the biliary tree, your alkaline phosphatase, which is another enzyme, that may be another substance that you're looking for, that may be elevated. So those, along with your history and your physical examination, you do your laboratory tests to help to conclude or to assist you in making the diagnosis of gallbladder disease. You also want to check your the enzymes that come from the pancreas, because we also know that there's a stone. A stone can also block the pancreatic duct, leading to pancreatitis. So you can do your pancreatic enzymes, your lipase, your amylase. And then you would want to go on to do your imaging study. And the main imaging study that is used is an ultrasound that can be done quickly, that can be done by the bedside. You can do an ultrasound to look at the condition of the gallbladder, see if there's stones in there, where the stones are located, to see if there is inflammation of the wall of the gallbladder, or there's fluid surrounding the gallbladder. So those are some of the tests you use. And they're much more sophisticated tests that we don't have access to here, which is called a HIDA scan. That's a specific test to the gallbladder. It's like using imaging and what you call a contrast that you inject in the vein, and then you take images of that contrast as it goes into, it is concentrated in the liver and is excreted by the bile duct, and it goes into the gall bladder. If when you take that test, you do those images and you do not see the outline of the gallbladder, it is indicative of acute cholecystitis. Because remember, we said acute cholecystitis usually occurs if there is a blockage at the cystic duct or the outlet of the gallbladder. So if there's a blockage there, the contrast that you would have injected into the patient does not get into the gallbladder, and the gallbladder does not light up on this scan. So that scan is called a HIDA scan. It's very complex. I don't really want our audience to focus on that, but if you want to and you're interested, you can do more research on it. That's called the HIDA scan, but we do not do that here. And then we have another test that you can use quite often that is called a ERCP, which is endoscopic retrograde cholangiopancreatography. And that is a specific test as well, where you pass the camera, like a scope, down the mouth into the stomach, and then you go into the duodenum or the small intestine, and there's a camera at the side, and that camera can look inside of the bile ducts and see if there's a stone, and if there's a stone there, it can also be retrieved or removed. So these are more these tests are more sophisticated tests that can be done. However, we do not currently offer them here in the Federation.
Let me ask a question. You have equipment at the hospital, and you have doctors asking for certain tests to be done using this equipment. A doctor always in a position to read the results, or you have a technician who would have to provide a report and give it to the doctor so that a more wholesome understanding of what is being seen. You understand? Because you can be a doctor, for example, and you recommend a particular medication, but you're not into pharmacology, so you might not be aware of the physiological properties. But yet all you know as a doctor is that this is what is normally prescribed. Who does the interpretation of the results from these equipment for the doctor? Is it a part of your training, or you rely on the technician, those who specialize in that area, to assist in elucidating the whole
Usually,
environment?
though, if you use a test quite frequently, you usually familiarize, or you should familiarize yourself with the interpretation of that test. So I will give you an example. I would order a chest x-ray. So I should be able to look at my chest x-ray and come to a conclusion of being able to use that x-ray and diagnose. So the technician is the one who carries out the test, but usually the doctor interprets the test. And for most of these imaging studies, we have our specialist who's a radiologist. So that lies under the domain of the radiologist. And that individual have in-depth knowledge of interpreting some of these studies and these images. So if we, as a doctor, I see an x-ray and I'm not sure or not clear what is there, I can then collaborate with our radiologist and ask, oh, can you look at this x-ray for me? Can you interpret it? The same way with the CT scans that we do. So the The technician would carry out or perform the test, and then the radiologist would then look at it and write his or her report on this test and give it to the doctor. But a good surgeon should be able to look at some of these studies and be able to grossly say what is going on. We may not have all the knowledge and the detail as the radiologist, which is a specialty of medicine, but we should have a general understanding of what's going on so that we can better help our patient. But the radiologist is responsible for interpreting the imaging studies.
You know, as you move upwards, so you have A, you would see something, but still you, as a doctor, you want to be absolutely certain as to what's going on. So you want to do something above that with better resolution.
Correct.
Then even after that, if you're not satisfied, then you go to the highest possible resolution. Which equipment is really for the highest? Is it the MRI? It shows more than the CT scan or the
But it all
X-ray?
depends on what you're looking for. Because each system, organ, whatever you're trying to study or the doctor is trying to evaluate, it may require a different level of testing. But if you have, for example, you have someone who you think have a fracture of the wrist, you order an X-ray. An MRI can tell you that there's a fracture as well, but you don't want to go to that higher level testing when a simpler test can also tell you. So that is how you manage and use your resources as well efficiently.
Now, we have given the listeners information about the symptoms, and with the symptoms, you have to know how to treat it. How is gallbladder disease treated?
Okay, gallbladder disease, like most other disease, once you've made a diagnosis, you can always go ahead and start treating. What we commonly do, and there are different schools of thoughts, it can be treated medically or conservatively, and also can be treated surgically. So when I say conservatively or medically, that patient who's diagnosed with a problem in the gallbladder, you can have, whether it is a cholecystitis or cholangitis, you can then treat that patient with antibiotics to help with the infection or the inflammatory process. You can treat that patient with things like pain medication. So you usually hospitalize that patient, give them IV fluids. You want to make sure, especially if it is a problem with the gallbladder, a low-fat diet. We also said that earlier, that fat is a predisposition or predispose the gallbladder to having infection or inflammation or as it responds to the fatty meal. You can also make sure that that person gets the antibiotics, the pain medication in that sense, and you can do endoscopic intervention. We spoke earlier of the ERCP. If we have a stone that's stuck in the common bile duct, you can use that test to diagnose. It is diagnostic and therapeutic. It can diagnose that there is a stone in the common bile duct, and it can also remove that stone. And there are other things. Surgically, you can remove the gallbladder, because once the gallbladder has gallstones, that gallbladder is no longer functioning well. So we do not just go in and take the stones out. That gallbladder would have to be removed. And we can do that in two ways. We can do that laparoscopically, where you use multiple small ports on the abdomen, or you can do a bigger surgery, what we call an open cholecystectomy. So you can do a laparoscopic or minimally invasive surgery, or you can do an open cholecystectomy.
Can we perform both of them here?
Can we
The two surgery.
The two type of
Yes. We have the capacity to do that.
Currently, we're not performing laparoscopic. No, we do not have that capacity. Dr. Wilkinson was able to do that when he was here, but currently we're not doing that. So we'll just usually do it open.
So we have lost that capacity.
We have lost that capacity.
Unfortunately. What is the function of the gallbladder, and what happens if it is removed?
Okay. The function of the gallbladder, as we said, is to store the bile. It's like a storehouse. So it stores the bile. The bile is made in the liver, excreted through the hepatic ducts, and goes through the cystic duct and into the gallbladder, where it is stored and concentrated. We say that the gallbladder has a capacity to hold 40 to 60 milliliters of bile. So that is the function of the gallbladder. And once it is needed, it is then released by the gallbladder and enters into the bowels or the small intestines. If a person is diagnosed with gallbladder disease and have a cholecystectomy, which is the removal of the gallbladder, no, the person can live without the gallbladder if it is removed. It's not one of those essential or significant organs. You can live without the gallbladder because the function of the gallbladder is to store and concentrate the bile. If the gallbladder is removed, the liver will release the bile on demand and release it into the small intestines. So you can live quite comfortably after cholecystectomy without having a gallbladder.
But there's always a probability that the liver might release the bile at a time when it is not needed.
No, that's not how it works. That's not how it works. No.
So where did it have to be stored in the gallbladder instead of going directly from the liver to the area where it is needed?
Interesting question. Why is it? Well, remember at this point now, once the fatty food gets into the duodenum, then the liver would release some of the bile to help in the digestion. I would just tell you this, in the absence of the gallbladder, you would have not lost anything. But you're asking a question that I don't know specifically how to answer. I may be
because you have a link that is missing.
You have a link that is missing.
The link was the storage.
Yes.
And then there would be something that would stimulus, so say,
Yes.
to get it out of storage.
Yes.
Because if there's a need to store it, it means that you might not have the need to use it in an impromptu manner. And then whenever that fatty acid rises, the level, the concentration, then it would stimulate the storage, which is the...
But I'll tell you what, I'll give you another example. Like, for example, you go to the bank and you withdraw your money to use it. But do you necessarily need the bank? You can always hold your money in your house, and when you need it, you use it on demand. So it's like the bank in that instance is storing your money or housing your money. But if you eliminate that bank, that doesn't mean you don't have your money or you don't have access to it. Do you understand what I'm trying to say? In that instant? But we don't lose anything. Just to know that you don't lose anything if you don't have the gallbladder, because the gallbladder does not produce the bile. So the bile is produced in the liver, and once it's needed, it is released.
Produced upon demand.
Yes, it will be given on release on demand.
Unless persons might just be putting on weight because they don't have that important bile component to assist in the breaking down of fat.
No, that is not so. Remember, the gallbladder does not make the bile, so the bile is still there. The bile is made by the liver, so that bile will still go into the duodenum and emulsify or break down the fat, so the person doesn't have to gain any weight.
Okay.
You're just removing the storehouse per se, but it doesn't do anything but keep it for a while. Just like the bank keeps your money for a while, but when you need your money, you can always.
When you need it, and that's the stimulus.
Yes,
now.
but then
the need becomes the stimulus.
But then that's what I said earlier. What if you don't use the bank? You don't have to store your money in the bank. You don't necessarily, once you need your money, you take it out your pocket. You could store it under your bed, if we're being technical. You don't need the bank. It is not an absolute. That's what I'm trying to tell you. It's not an absolute in that instant. You could eliminate it, but it doesn't stop the function and the bile that is needed and necessary.
Okay, good. Well done. How can I reduce my risk of gallbladder disease?
For us to reduce the risk of having gallbladder disease, one of the most important things would be looking at the risk factors that we spoke of earlier. So you eliminate some of these risk factors. Some risk factors are what we call modifiable, and some are non-modifiable. So the things that we can control as a risk factor, we try to control it or improve it or eliminate it. And there's some risk factors that we have no control over. We don't have a control over our race. We don't have a control over our gender and stuff like that. We can control things like how we eat, our diet, to make sure that we do not have a diet high in cholesterol, things that we can do by losing weight, by exercising, decrease the cholesterol that is inside our bodies. All those will help to decrease your chance of developing gallstones, because we said it is seen mostly in persons that are obese or morbidly obese, overweight. Those persons who are less active also has a increased risk of developing gallstones. So those things that you can change, and along with your diet, having a diet high in fruits, vegetables, and fiber, would decrease the chance of developing gallstones.
It is important that it is amazing that persons' fat seem to always be an issue. Get rid of the fat. The body can help you get rid of the fat. Take exercise, get rid of the fat. But there are certain systems in our body that rely heavily on fat. The transmission of nerves. You got the myelinated area there where the fatty area would help in the transmission of nerves. So if you do remove 90, 80%, 99% of the fat due to bile and exercise, what would become of the transmission of nerve impulses? People then become nervous because you have you understand?
Not
There are
necessarily
areas where fat will be needed.
We
and
know.
you also need it for a little insulation
We-
to keep the body warm.
keep
So
the-
why we always attacking fat per se?
Most of the issues with fat is having too much of it. We're not saying that you don't have any fats, because healthy fats are good. Remember, balanced diet includes your healthy fats, your proteins, your fruits and vegetables. You
The
get those.
unsaturated
Yes,
fats,
yes.
yes.
So you do need fat, but most of when we speak about being overweight or being obese, that means that you have a little bit more fat than you actually need.
The saturated type.
Yes, yes, the unhealthy type of fat. Okay?
Okay. I think that we have done an excellent job. I don't know if you realize that our hour and 15 minutes.
What?
That hour and 12 minutes. So I don't know if there's anything. But how is the surgery with respect to the removal of the gallbladder? Do we have a lot of them around here? Do we carry out a lot of surgery with respect to gallbladder issues?
Yes, well, it is among the list of more frequent surgical procedures done, which is called a cholecystectomy. So it's done, as we said, mostly in women. More than 90% of the cases are usually, more than 95% of the cases are usually going to be women. So we do perform cholecystectomy here.
Okay. I really did enjoy this topic, and I'm sure a lot of persons would be not only more aware, but more current, more up to date with information relating to the symptoms, especially of the gallbladder disease. And but a surgery, the last time we spoke about acute appendicitis, we spoke about the length of the surgery being about an hour, hour and a half. Is it a little more complicated than the acute appendicitis, the surgery on the gallbladder? When you go into a gallbladder, do you remove it, you clean it? Could you offer medication to cleanse it, like antibiotics, yes? What about to reduce whatever might be blocking the pathway? Do we have that stuff?
Okay. There are some drugs and salts, different drugs or tablets that you can take to help destroy or break down the stones. However, these tablets are very ineffective. Why would I say they're ineffective? Because you have to take them for long term 2-3 years. Sometimes once you've broken down the stones, then once you stop taking the drugs, stones are reformed again. And also, these medications have quite a lot of complications associated with them as well. So, in that instance, no, it is not common practice in first world countries, in developing countries, to take drugs to help destroy or eliminate stones. Usually, once the gallbladder starts to create or form stones, that gallbladder is not functioning well. So, it doesn't have much use. And it is an organ that we can live without. Okay, so it's a non-essential organ. You can live without the gallbladder. So, as compared to doing a cholecystectomy versus an appendectomy, of course, the cholecystectomy is a much more involved procedure, and it takes more time. And the length of time depends on the surgeon, depends on the technique that you're using as well too. So you could have a cholecystectomy being done, and it also depends on the constituency of the patient. If the patient is more obese, the condition of the gallbladder. So there are many factors that determine the length of any surgical procedure. You have the technical skills of the surgeon, you have the conditions of the patient, you have the conditions of the organs. So an average time for a cholecystectomy can be around 2 hours.
Okay.
And that depends if you're doing laparoscopically or you're doing it open. Because if you're doing laparoscopically, it'd likely be done in much less time, an hour thereabout.
We looked into this topic and we would have treated it well. We would have explored everything that is there, at least to the understanding of the general public. But I want to ask you a question. When you have, this is you know, when you have a surgery to perform, how is your night? What do you do mentally, psychologically to get ready for that surgery? Do you lose sleep? Do you make sure you get sufficient sleep, even though you might not be able to sleep that well? Tell us about the life of a surgeon getting ready for a surgery the next day.
Okay,
Do you get a little nervous when you pull up at the hospital and have to jump? Well, not stress. They got positive stress. That would help us if you're taking an exam. You have positive stress that would cause you to perform real greatly in the exam. Is it the same like a surgeon? You pull up and you walk with confidence and you stride into that room, get yourself all prepared?
Of course. It all depends. Because your years of service, the frequency in which you do any surgical procedure would always affect your emotion and your energy. But if you're like me, and any surgeon who loves doing their work, there's a kind of high you get, a rush you get. And usually you want to get a good sleep the night before. Oftentimes, I'm reviewing certain things. I'm looking at the topic, making sure you look over the anatomy of certain organs the night before, because you're trying to make sure you're keeping abreast and keeping things fresh in your mind. You want to make sure that, because you're thinking that once you have everything and you're sure what you're going to do, it cuts down on your surgical time, it increases your confidence and stuff. You want to also get a good rest, but if it's something new and exciting, you may have difficulty sleeping, and you're waking up and you're going over it in your mind. And of course, on the morning, there is a kind of nervous excitement. If you love your job, it's always there's positive stress.
Right.
There's that energy that you have going in and you're thinking. And usually, for me, I'm running through the procedure in my head.
Exactly. That is what I was coming to.
Yeah, you have to. You start thinking, okay, this is what I'm going to do. And this is what you're thinking. And you're going through the steps. Sometimes you're thinking it out. And you're thinking, because also, if you're any surgeon worth your salt, you're thinking what are the possible complications and how to avoid them. And you should always ensure that you do not get yourself into a case that you cannot get out of. So you have to think, what if A goes wrong, or what if B occurs? How can I get it? And so you're thinking of solutions along the way too. Because at the end of the day, you want to first do no harm. So yes, it's exciting for us once you're doing Once you're doing surgery, you get that high, you get that energy there.
Yeah, I can imagine. And that is when you have something planned. I have surgery the 27th of February. I'm going to be doing an appendicitis, back operation, or something, you just call to the hospital, not knowing exactly what you're going there for. You might get some general information, the gunshot wound, back, and something with gunshot wound, you might shoot somebody here and the bullet end up all over the place. You understand?
So at that point, you're thinking all of the different scenarios as possible. But of course, life is not, written. There's not a checklist. So you may end up getting something you did not expect. But if, for example, I'm called and I say there's someone who was stabbed in the back, and you ask the information, which area, how high, how low, and they give you that general area, you start thinking of what to expect. And oftentimes, because we do on-call, what we call ambulatory, you're going on demand for the surgeons, you would then get some information. You may get an X-ray ahead of time. They can email you an X-ray, and you can look at it, and you have an idea what you're going into. Sometimes you don't. If a patient comes in and they have something like a perforated ulcer, certain things you're looking for on the X-ray. So immediately, if that happens, I'm starting to think, okay, what am I going to do? What do I need? So you start thinking ahead so that it makes it easier once you get to the hospital. You're more on target. You're reminding your staff, the nurses who are assisting you, oh, we need this on the table, we need that on the table. So you're planning ahead for your procedure.
Excellent. I just can imagine, because we having some gunshots around here, and there's always a possibility that you'll have to do some work on some. We hope not.
We hope not.
But there's always a probability that would happen. I don't know if we can use maybe gunshot next time and have a discussion so the guys them out there could really understand how dangerous it is and how much work the doctors will have to do. Because you hear about times when a shot is lodged somewhere, and the surgeons them decided that it is better to leave it there than to move it. How do people explain that to the general public?
But we could do that topic another time. But I'll tell you what, with that, we still have that mentality where we saw the John Wayne movies, and we thought that once you got out the bullet, all was well. But that is not how real medicine works. Bullets are metal objects, and people live with metal plates and stuff inside their body. We don't usually go chasing after the bullet. It's the damage that the bullet does and the pathway that it takes, because the bullet is a high velocity injury type of injury. So it's the damage that it causes in its trajectory inside the abdomen. So you get shot in one place and you have injury to the liver, you have injury to the major blood vessels, you have injury to the stomach, you have injury to the bowels, and that is what you're thinking as a surgeon at that point. So we're not going chasing after the bullet, because once the bullet has stopped, it has done its damage and it's not going anywhere. So you don't want to, because I remember a patient came to the hospital, the mother, and every minute she's behind me, all the bullet. But her son had very severe injury. He had a lung that was collapsed. He had injury to, I think, was the windpipe or the trachea, different things like that. But her focus was on the bullet. And we were able to remove the bullet, because eventually the bullet was became very superficial, just under the skin of the back. But the damage is what the bullet does in its movement, in its path. Once it has come to a standstill, we are not so interested in the bullet. So persons are alive and well and living with a bullet inside of their bodies, but it's the damage you go seeking after and trying to repair.
So a key gem for a surgeon is to see an entry hole and an exit, because that will give you general comfort that at least it came out.
Yet again,
entry and exit?
No, remember we said that really doesn't change. It's the damage that it does on its way into the body. So whether there is an exit per se doesn't really, the surgeon, it doesn't change anything, because it can go in and out and create quite a bit of damage, or it can go in and stay in and does not create as much damage, because it depends on several different factors. It's a high velocity type of penetrating injury, a gunshot wound. It all depends which organ it injured. If you have a bullet that goes in, one of your greatest fears is that it injure any of the major blood vessels, because that person would what we call have internal hemorrhage and bleed out. Okay, so those are the main things. You want to make sure you want to think of the damage to the organ that the bullet caused. Not that there's an entry or exit wound, and not that the bullet is lodged somewhere, because we don't usually go chasing after the bullet. Once we do the surgery, we're looking to revise and check all the major and significant organs, make sure that there's no holes there is no leakage, because if there's a hole in the stomach, the gastric content will leak into the peritoneum, stuff like that. But we can discuss that in
Of
great
course,
detail
we shall.
another
But
another day.
I want to differ just a little bit when you say we don't go tracing, but suppose the bullet is lodged in an area where it might block a duct. Remember we spoke about the duct being blocked with the gallbladder? A bullet could well get in that area and maybe have it
If a
blocked.
bullet is inside a duct or inside the bowels or anywhere that is easily accessible, you take it out, because that is always going to be important for the police officer in their investigation, their assessment. But what I want to make sure that our public understand that this is not the movies and the stuff that we get excited about. We're just looking to see what damage that the bullet would have caused, more than looking for the bullet. Because as I said again, once the bullet is stopped, what if it is lodged somewhere in the spine and you cannot have access to it? Because remember we said, first, do no harm. We do not go looking for it. We may injure major nerves and stuff. We do not want to create more problems than a solution. So I want the public to understand, is not looking for the bullet, is solving the injuries that the bullet would have caused.
Yeah, okay. We have in law that once perpetrator would have inflicted wounds on a victim and that person dies within a year and a day, that person can be liable for the death of. How do doctors keep track to say, well, this person died as a result of the action of the perpetrator? How do we really keep track? Because that day, the year and a day is key in the court. Because once somebody dies within a year and a day of a particular event happening, and how do we keep
To
track?
be honest, that mostly would be the work of the prosecutor to make the connection. The job of the physician or the doctor at that point, I'm not a lawyer, but the job of the physician at that point is to give the medical report, say exactly what has happened. And that's all the doctors
Yeah, but then for a year and a day, what is going on in the interim for one to ascertain that this is exactly what caused it?
But then if the person meets their demise, then we have an autopsy and we could see if there's anything that would tie into the original injury that the person might have had. Okay?
Autopsies are so important. Do we have any locals in that area?
Yes, we have we currently have two individuals. One is a local, a female, Dr. Philip, and we have a resident who's a Cuban, but he's been living here for many years, Dr. Adrian Nunez. Both of them are clinical pathologists.
And I would like to get one of them just question one of them sometime, because you can shoot a man in his head and everybody might conclude or draw inference that it was a result of that bullet. But then if the person was up on a high building and he fell as a result of that, he could have gotten a heart attack on the way down, and he would have died from a heart attack rather than the injury inflicted from the bullet.
Okay, but you're just doing a hypothetical. That's
Yeah,
a little bit
no,
too
that could-
straight.
that- yeah, that could-
But
that could
hence the
happen.
importance of the
Of the
autopsy.
autopsy,
And once you're
right.
doing an autopsy, the pathologist usually review all of the organs, especially the significant one. And of course, they're going to review the brain where the bullet went in, or so those, it all depends on what it is.
Sorry to go off obliquely, but these are things that would come up
Yes.
as you have discussions with
Yes.
people. So
So that's why your autopsy is very important, be able to see what injury or damage to the organ
So
and
we
come
need
to a
to
conclusion.
encourage more locals to go and specialize in that area. That is what I'm getting at. Because you had somebody coming from Barbados almost forever, Dr. Jones, and I sure he might have built a whole country out of the revenue he would have generated from our local circulation. And that is why we have to encourage people. Well, I don't think he comes here anymore. But every time you read a report, it was pathologist Dr. something Jones, I believe. So it's an area for us to specialize. But maybe I could ask you, are there any other areas? I know that we would have concluded our discussion on gallbladder disease. Are there any other areas that there's an urgent need for specialization in?
Oh, there's several, because still, even though we may have one or two, sometimes there's more as persons move on, persons may retire. We have things like a nephrologist. That's the doctor that is responsible case for the kidneys, because we have quite a bit of patients with with kidney disease. We do not have a local ophthalmologist, a homegrown ophthalmologist. We need things. We don't have a neurosurgeon in living in the federation and working in the federation. We don't have, several other. We may need more cardiologists, persons who specialize in dealing with the heart and the studies around the heart. Okay, apart from a neurosurgeon, we need a neurologist. That's the study of the brain and different conditions that affect the brain. The neurosurgeon would operate on the brain. So there are quite a bit of specialties that we do not currently have in the Federation. But we do have the main or the core specialties like general surgeon, internist, gynecologist and obstetrician, those areas. We have psychiatrists, we have orthopedic doctors. We currently have a urologist on staff who is Cuban, so he's on contract. We have a vascular surgeon currently. We have a nephrologist who's also Cuban. She's on a contract living here right now in the Federation. So the core specialties we have, but some of the more, the smaller areas, also, our population is small, I think I mentioned that, and sometimes it's more difficult to contract or to draw certain specialized area to the Federation.
Because internists, I know that we had three of them, Dr. Joe, Dr. Hobson, and Dr. C. Haley.
Dr. Lawrence is also an internist, remember Dr. Lawrence? Yes, female, Dr. Lawrence.
Okay.
Caroline Lawrence.
Caroline Lawrence, yes.
Mm-hmm.
And Dr. Joe would have gone into politics, the present Prime Minister. I think that.
We also have Dr. Babu. I forgot to mention Dr. Babu is here.
Dr. Babu, yeah, because he deals with discussion with diabetes and such, so it might be. Where is he from originally?
He's from India.
India?
Somewhere in India.
But sometimes I always get the impression that we are short an internist. I don't know if I might be correct, but sometimes I get that impression.
Well, we need to encourage the younger generation, some of the young doctors, physicians that we have, they could go on and study. We always need more because there's such a crisis with our diabetics and our hypertensive patients and so.
Are we on a drive? Are we on an active drive, going to schools, going to the college, encouraging people to maybe become doctors in particular area? Are we on a drive at all, our health system? Are we on a drive to even get nurses sometimes? Is there a drive?
Well, when I speak of medicine, we have quite a bit of physicians. What we would need more of our physicians to do, like not just stay in general practice, is to go on and specialize or subspecialize in different areas. But in terms of doctors in the Federation, in the ratio doctor to patient, we actually have more doctors than patients. But in terms of certain specialized areas, as I mentioned before, we may lack some of them, or we may be short.
Do you teach? Because I know you indicated that you like teaching. So do you get an opportunity to teach? Do you call a set of nurses who work in the theater and maybe have sessions with them? So when we're doing that, this is what So right away they can jump. If you call them 2 o'clock in the morning, they're always ready to.
I remember Dr. Wilson and I did several sessions before. Oftentimes the nurses would have a little conference. They would invite the doctors to speak on a particular topic. I would have given sessions also to the EMS when the new batches come in to be trained. We have, if there is any kind of conference, you may ask a doctor to speak. We often, well, in the past, we had sessions, weekly sessions with the young ER physicians as well, talking about different common emergency room conditions. So I would have spoken to them many times of different surgical topics. We would have gotten the internists to speak, the orthopedics, so to make sure we do that. And I also get an opportunity to work with some of the students from the medical schools, whether it's the Windsor or the UMHS school. So I work with them currently. Last week I was there, I did a session on, I think it was colorectal cancer, and they come to the hospital and we have discussions and sessions with them. So
Excellent. Because some doctors are great teachers. And sometimes the more you go around and explain yourself to people, you become more proficient as well.
that is so true.
More proficient. Well, could you just sum up what we would have spoken about tonight, the gallbladder disease? Just give us a brief summary. It doesn't have to entail everything, but the major takeaways that you would like listeners
Okay.
to have.
Okay, I just want to remind our audience that gallbladder disease is a wide topic and it consists of quite a lot of different conditions that affect the gallbladder. We have the most common in having gallstones in the gallbladder, and usually that is the starting point to have different pathologies. Cholecystitis, we say cholangitis. We can also have gallbladder cancer. We can have polyps in the gallbladder, but the most common condition is having gallstones. It is more frequent in females. It's more frequent as in females that are over the age of 40 who have multiple pregnancy. I want you to keep in mind the symptoms associated with acute cholecystitis, that is pain in the right upper quadrant, that is under your rib cage, things like nausea, vomits, fever. You can have what we call fatty food intolerance. You can have anorexia or lose your appetite. And when you examine the abdomen, we spoke about the right upper quadrant, you will have tenderness there that may be significant. Patients may also have things like jaundice, where the eyes become yellow. You can also have a complaint where they might say, "Doctor, I've noticed that my stool is much lighter than usual." That is an indication of there's some form of obstruction there in the biliary system. And so once you've made that, you can then go on and have your laboratory tests and studies looking for infection through your white blood cells. You're looking at the liver panel, and that would tell you if there's a problem with your total bilirubin. That would tell you if there's a problem with stuff like your alkaline phosphatase, so you need your blood works, and you would assist those by getting your imaging study where you do an ultrasound. You can do a CT scan of the abdomen looking to see if there's a gallbladder disease. You can also do what we spoke about, a HIDA scan, and you have things like your ERCP, which are much more sophisticated testing. And once you've diagnosed a patient with having gallbladder disease, the treatment is usually medical or surgical, but definitively the gallbladder would need to be removed.
Excellent. I think we got more than we bargained for, and I like that summary. You touched on the key and pivotal points, and I think that our listening audience is more informed. I think it was rather instructive. You brought down the explanation as much as possible to the layman's term. You know, some words are highly specific. I usually tell people that I prefer my children to refer to me as daddy rather than pops or father, because that is when they start to jiff away. You understand? And there are medical terms that you just cannot find substitutes for.
Yes.
So sometimes in our quest to better educate people, we struggle with those very highly specific words that cannot be substituted. But sometimes a little explanation could add some fuel to the flame of understanding. And I think you have done an excellent job. I think every friend, family member, your mentor would be extremely proud of you, and you continue to do well. And I can sense the growth. I can sense the growth because sometimes I'm somebody who would always have some follow-up question in oblique directions, and you would have held up well, and I want to congratulate you on your presentation this evening and hope that you will continue to come back. You owe us a program next week. I don't know if you remember that. You say, I know I can miss this week, but I can make up with 2 consecutive programs. I don't know if
I remember.
am I right with that echo? I could only echo facts, Facts can't change. There's no substrata of the fact.
Did I say
I
that?
can only, yes, I can only echo facts.
It must have been done under duress.
Duress. So
Yes,
I could ask you to say that.
We can
That's a
we can
criminal
work on
offense.
something. We can work on something.
Yeah, but
for
if
next week.
if you're in need of the rest, we can do that. But we enjoy the topics very, very much.
Yeah, we'll continue doing them because
we-
I do enjoy doing it
We
too.
enjoy the topics.
It's part of my way of educating the public and reaching out. Yet again, I told you part of my core is teaching.
Right. Right. So we can teach the general public from here.
Yes, we
Because
can.
some of them don't have an understanding of what really takes place. Sometimes, a common thing in our culture, in our federation, as long as somebody start feeling a pain somewhere, 95% of the time they say it's gas.
Yes. Oh, yeah.
We love to say it's gas because we're hoping for the best, and all we're thinking is that some gas molecules get trapped somewhere in the blood thing and traveling. I say, I'll talk about gas one day I can get embolism of the brain. But that's a common thing because people always want to hope for the best. That it is just gas and they could take some warm tea and it would go.
Yes. Some warm tea always
will
solves
go-
everything.
it
That's
will
a
go
cure
away.
for everything.
Yes, so we do enjoy. We have about another 15 minutes. I will just let you set up yourself because we do not always make it to the 2 hours. But my thing is that an hour or
Yes.
just over an hour, and I can have conversations, but you can prepare for a particular topic and we'll have it. And just like how I asked you how you feel getting prepared for surgery on a particular, I think that those were relevant questions because people would like to know what goes through the mind of a surgeon the day before or the night before they get ready for this all important. Because everything is a risk.
Everything is.
And you have to be precise in your delivery, but it's not all the time you can reach that 100% precision. And you're just hoping that you're well within the limit or plus or minus 2 or 3, whatever. You understand? There's a success rate with every surgeon. There's a success
Correct.
rate. So nobody would think that surgeons are perfect, and people they would not lose their lives as a result of going through surgical procedures, because that could only happen in heaven. Everybody is completely different, and we want to encourage people that we have some competent surgeons around here. They would have been well taught, and especially you in particular, who came through the very competent hands of Dr. Wilkinson. I think that the confidence level of patients showing up at your office or organizing procedures to be undertaken in the theater, I mean, that is brimming. And I think that you would have learned well. I think you learned well, quite well, how to learn, because people have to learn how to learn. And you can't get tired of learning. And I really I don't want to express my envy of that combination of mentee and mentor. But it's not only me. I think it might be the envy of almost half our population. Many persons would have wished that they were in your position to be mentored in such proficient a way. So you just have to keep doing what you're doing, and just wish you well in your quest for continued success in that risky environment. I would like to say risky because there's always a probability that something might not go how it's supposed to go. But with confidence, that would be diluted to insignificance. And you're doing a heck of a job based on reviews that I've been getting, even without asking for them. Okay?
Thank you. Thank you. And I want to say good night to the audience. It was a pleasure being here tonight.
Yes. Okay, we'll take a break and allow the good doctor to get her momentum.
Fellow citizens, near and far, join Newish Natal on Sugar City 90.3 for Fear No Favor.
Where is the cancer man? No runner come out for war.
Tune in to 90.3 on your FM dial. Log on to SugarCityFMSaintKitts.com or download Simple Radio app from the Google Play Store. Enjoy Newish Natal every Thursday night from 8 to 10 p.m. as Newish Natal tackles the issues and take your call. Fear No Favor every Thursday night from 8 to 10 p.m. on Sugar City 90.3 FM.
Would you stand up and see your country dying and never lend a helping hand? Would you see your children's future dwindling, creating much disillusion? Or would
After the good General Surgeon, Dr. Osborne, would have made her exit after a lovely program here tonight. I didn't want her to be here while I discuss this issue. Now, I want to talk about cricket because I feel that we are failing as administrators of cricket. We have been entering teams to play in tournaments, and we are not having any local cricket league with respect to 3-day cricket or 2-day cricket. And persons are getting up and selecting. Over in Nevis, they had trials. Here, we have a tendency of maybe just picking a few people who we know of. But people evolve, and those who you may feel might be on top of the cricket, you might have youngsters coming up who could perform better than them. But yet, how would you know? How would you know if you don't carry on leagues throughout the country? What happened to the school? What happened to Greenhouse versus Red House? What happened to Bassey High versus Washi, Sandy Point, CFBC, Sadlers, Vorchells, Keyon? What happened to those competitions? Our cricket is slowly dying. And I believe that persons in the administrative position, they are quickly running out of ideas. And maybe it is just pride. But I believe some other people should take over. If it is too much for one person as a president, we'll have two presidents. We have to try something new. It is unfortunate that cricket is going on at Warner Park. I had absolutely no idea that there was cricket over Warner Park. And cricket in Nevis as well. I was talking to somebody and the person was telling me that she was scoring. And I said, so you're in St. Kitts? She said, no, she's in Nevis, scoring. But she said there's cricket in St. Kitts. I said, I had absolutely no idea that we had cricket down here. How can we do better with respect to promoting cricket and the involvement? Because sponsorship would only follow good and great performances. Sponsors, they can just get up and sponsor something for the sake of sponsoring it. We have some real good humanitarians, philanthropists who've been donating, contributing towards the cause, but then we are not capitalizing. We have so many cricket grounds throughout, good cricket facilities throughout St. Kitts. You go to Warner Park, you go to Connery, you go to Keyon, you go to Molyneux, you go to Mansion, you go to St. Paul's, you go to Sandy Point, you go to Vorchells. You come right around. So many facilities when compared to Nevis. And sometimes we have to think objectively. Wouldn't it have been better to put that stadium over on Nevis? We don't deserve it. We do not deserve it. Don't care what people think. I don't think that Kittitians really deserve that stadium and that big investment we would have taken in cricket. We cannot find people going anywhere. We are yet to produce a player on the senior West Indies team. We are not making any progress. I don't know whoever would like to talk for the sake of talking and not denting their pride. They have to wake up. We're living a lie. We're not making any progress in the area of cricket. We are a good host to cricket, but we are not producing the facilities that we have. It is not being manifested in the production of players of better ability and capacity. And it's a disgrace. A real disgrace. And we have to come better than that. We have to come better than that. Don't care what explanation they're going to give you. They're not doing a good job. And I don't believe they have the capacity to do a good job. I even believe if you give them the money that is necessary to host something, it wouldn't come off in a spectacular fashion. Because these people seem as if they are dwarfs with respect to mental ideas as to what we can do. Dwarfism just taking over. You know, just an avalanche of morass when come to the cricketing environment. And it is hurtful because we put down those facilities for a purpose. Maybe a lot of those guys who would have gone off on a tangent, who have gone off on the broad path instead of staying on the straight and narrow, had they been better engaged on these facilities that we have throughout St. Kitts, I mean, we could have been singing a different song. We could have been singing songs of praises. Basketball courts all over. And we can't get a Kittitian making any advancement in the line of basketball. So many courts all over. What else do we want? It got to be the administration. Because what we have is a real recycling of persons from one department to another department, another area of sports, and we're just not heading anywhere. Don't talk about track and field. Don't talk about sport. We're not reaching anywhere. Yeah? The times our seniors are performing and running, this is what people in junior school, in Jamaica, and so running. We have to look at the region. anytime we can't even get a good 4x1 relay team. We always have just one or two persons out there trying the best endeavor to see if they can do something. But even if they perform above average, how can we get a relay team? The last relay team that we had with Alistair Clark and Jason Rogers, and they got third and they collected some funds as a result of that. I mean, where all this gone? Where are this gone? Some people just have to give up. Some people just like the status of hearing their name called with respect to a particular sporting activity. But nothing happening for us. Nothing is happening. You can't even organize a league. The two-day league to play the three-day matches. And that is why West Indies cricket is suffering. Because when West Indies cricket was at the helm, we had good performances coming from the smaller islands. Andy Roberts, Vivian Richards, Courtney Ambrose, Keith Atherton, Stuart Williams. And we could go on and on and on and on. But when you see nothing happening in the smaller islands, West Indies cricket just tend to fade away. Yes, they did a reasonable performance the other day where the young Shanda Paul guy got 207 or something like that. But we need to be consistent with that, and we shall see what happens as we progress along that spectrum of recovery. At what rate would we recover, or would you just reach a peak and then go back down in the valley? And that got to do with the administration of the cricket in our region. I could talk about St. Kitts Navy. I'm not impressed. Well, let me say St. Kitts. I'm not impressed at all. I am totally unimpressed with the effort being put into our cricket after such big investment. That money could have gone elsewhere to do other things. Number one, they spoiled Warner Park. That's the first thing. Warner Park was one of the biggest grounds. And you take such big area and condense it in such a way that even somebody hits a six, they feel guilty that might not have been a six on a properly constructed ground with the proper parameters. I mean, come on, man. We were edge ball going over the boundary, and we had such a big piece of ground there from the Bastia High School wall down to Lozat Road. And we just put us inside a matchbox. It cannot be pleasing to a lot of persons who knew what that area was like before. It is unfortunate. Now we have 2020, and we have a ground out there sitting down. Maybe we realize that 2020 is an area where people can generate income. You see, we think about sports tourism by inviting people to come and we're collecting revenue. But what about exporting some of our talents so that they can generate income outside there and bring money back into our local circulation, whether they themselves directly spend it or indirectly through their family members? We have to be thinking the next way. We're not producing. We're not producing in sports. And that is a fact. And we wonder, what can we do? Should we just take up some of the facilities and plant some crops and rotate some crops so at least the younger persons them could be doing something instead of utilizing the facilities them to isolate themselves and get involved in the smoking of weed and other kind of social behavior that might not be as productive as it ought to be to uplift our federation. That is what most of these facilities are used for now. An escape to get involved with groups and smoke what they want to smoke, drink what they want to drink, behave how they want to behave. Sometimes we might just have to take up some of those facilities and do crop rotation, because the investment is not being manifested in the returns. And it is a disgrace. You can't even get a single player as part of even our Patriot team. Yeah, people got to bring people from all over. Yes, franchises there be, yes, and we agree with that. But what about we hosting a tournament with intensity? 2020 is the way to go. They're going on to 100 balls right now, I think. The 100 balls are 60 balls. We have to start producing people who can generate income from the investment we would have made in sporting facilities. If we can't do that, we ain't ready yet. And I wish that it was practically possible to take up the stadium and put it up Nevis. They have cricket much more serious than we do. And maybe we should have had more input as to where to put a stadium. It is not paying us anything apart from when we are CPL and this and that. But we're not producing anybody. We don't have anybody around here doing much when it comes to sports. And it is rather distasteful. And for this protracted period of time, it is becoming now increasingly more frustrating. It is becoming bitter. And I believe that we are to look at it. Those who are involved and not carrying us anywhere just had to stop. I can recall when Mustafa Powell just couldn't make it on the big scene, just running, breaking records, and when it come to the big stage, he wasn't doing. And he said that his parents tell him, change your coach. And he asked them for what? They say you had to be in, just change your coach. Change. Sometimes you just need to do things and see if you get it from a different perspective, from different angles. Don't forget we have an entire 360. And in between those 360, you still have the sub-areas. So there's so many angles within 360. Anyway, we have come to the end of our program for tonight. And I would like to thank you for listening. And I would like to go all the way back and thank Dr. Natalie Osborne for gracing our space. And we're hoping to have many more of such programs. And I'd like to say thanks to Lourdes Thomas for really doing a proficient job here at the studio. And we want to continue to encourage her as she grow within the field of technology, within the studios. Okay, thank you very much.
The opinions and statements made by the host and participants in this program are not those